Good morning, everyone. We are really excited today to have Professor Kenar Jhaveri talk to us from New York. He is a professor of medicine at the Zucker School of Medicine at Hofstra Northwell, and he's also the associate chief in the division of kidney disease and hypertension at Northwell. I know Dr. Jhaveri for a long time. He's actually a pioneer in medical education, research, and many other fields in nephrology. So the introduction doesn't really do him any justice. He started, the AJKD social media platform several years ago. He's been leading onconephrology and many other fields in glomerular nephritis as well. So we are really excited to have you here. He's one of the foremost educators, I would say, in nephrology. Welcome, Kenar.
Thanks, Swapnil, and thanks, Baljinder. Good to see you both and the whole group here. Swapnil and I go way back from social media times and sharing a lot of stuff online that is exciting in nephrology. So today I will focus on, it's going to be all cases, so it should be a lot of discussion. If people want to jump in, put in the chat, feel free. I always disclose everything, but really nothing to do with this talk, but it's better to just be upfront with these things. Glomerular diseases in a cancer patient. So the way you should be thinking about it is it could be a paraneoplastic process. So it could be with both types of tumors. It can also be seen after stem cell transplant and also as a result of anti-cancer agents. But the first time this was ever described was actually 1922. Sir Galloway, described a disease of albuminuria in a patient with Hodgkin's disease. And that was the first association of what we would call a paraneoplastic glomerular disease back in 1920s. And then, a lot of connections have been made of different diseases with cancer. How do you define this? Now, this is sort of just, opinion, because there's really nothing proven in these type of situations. So any tumor, liquid, solid tumor, that's not directly related to tumor burden or invasion or metastasis, but has an abnormal, say, cytokine production, tumor cell production, anti-antigen, antibody complex, that then eventually leads to a glomerular disease. That's basically paraneoplastic. This is sort of the criteria that experts come up with. There's really no hard and fast rule. If you have minimal change disease and you have a cancer, if the cancer gets treated and the minimal change disease goes away, that probably was related. And relapse happens also when the recurrence of the cancer happens. So that's also another clue. And then you have other antigen, antibody clues, perhaps, that could be related, for example, NEL1 and a malignancy. So that could be a potential clue. So let's start with case one. This is a 70-year-old male with gradual onset of nephrotic syndrome. Really, edema on exam, unintentional 30-pound weight loss, no NSAID use, no rash. Heavy smoker for past 45 years. Blood pressure is not bad, but you do have edema on exam. Protein creatinine ratio is 8.8 grams. Albumin is 2.8, which is low. Total cholesterol is 290 and creatinine is 0.9. Serologies, ANA, Hep C, everything's negative. Immunofixation, anti-PLA2R is negative as well. Sonogram has normal kidneys. Patient started on, furosemide for edema management. What would you do next? Kidney biopsy, start ACE-ARB or SGLT2 inhibitors, PAN scan or a PET scan, start empiric oral steroids. Any thoughts from, Swapnil, you can probably read the chat if there's any questions or.
Yeah, people are saying biopsy mostly.
Okay.
I'm saying biopsy and one more person is saying biopsy. There's a vote for a PET scan.
Okay. The PET scans, at least here, are very hard to just order. And it's hard to get right away without some sort of reasoning. So, let's go back a little bit. This patient may have a malignancy, right? We don't know. There's a weight loss, but with some ANCA vasculitis, some GNs, we see weight loss too. So this could be a primary GN as well, but it's a nephrotic syndrome. So maybe there is more of a minimal change of membranous. This is sort of a schematic of a concept map of potentially GN pathology with associated cancers. For example, the one I want you to focus on is membranous. You can see here a lot of solid tumors associated with membranous. So, and minimal change, you can see more liquid tumors like lymphomas, leukemia. So the take-home message today really should be these two. If you see a patient with minimal change or membranous, and you're looking for a malignancy, you should be more solid tumors here, liquid tumors here. The rest are very rare. These crescentic FSGS, MPGN are not the most common things you see. And IgA nephropathy, as you all know, it is associated with GI tract. So we see a lot of IBD, ulcerative colitis, GI disorders with IgA, cirrhosis. So those tumors might also be the classic ones with IgA. So what is the mechanism, right? So it's potentially, again, postulated by, again, experts who write review articles, but there really no proven data. One is that tumor antigens could be very similar to endogenous porocyte antigen, right? So maybe something similar. Second is circulating tumor antigens form immune complexes. They get trapped and cause immune complex GN. Third, it could be that they get trapped and have subepithelial circulating antibodies. And fourth is an extrinsic trigger like viruses. Like, maybe the same virus is triggering the malignancies, triggering the GN, okay? So the kidney biopsy shows segmental membranous nephropathy. So it's not a diffuse pattern of membranous. It has minimal IFTA, mild vascular injury, and PLA2R negative. Okay. What should be the next step? Rituximab, tacrolimus plus rituximab, more intensive malignancy screening, test for more antigens like NEL1, thrombosplerosis.
Yeah, people are asking for NEL1 and more tests in the chat. Option 5, I guess.
Nobody wants to treat.
Or more intensive malignancy screening.
What if your center does not have this staining? Now what? Which is realistic, it's expensive. Only Mayo Clinic does this. So even I have to send it out to Mayo Clinic. Columbia is trying to do them, but I don't think they have all of the stains. So even within the US, if I had to do this, I have to send it to Columbia for Mayo Clinic for staining. So just practical reasons, what would you do if you didn't have number 5? Maybe number 4?
Yeah, there is a vote for cancer. Yeah, a couple of people are saying you just need to look for cancer.
Okay. So let's go back here. Segmental membranous nephropathy. That should be a big clue. So a lot of times when we see membranous nephropathy, it's more diffuse. And when you're thinking secondary causes, you think of mesangial proliferation a little bit. So maybe full house pattern, TRIs and the EM, and also the segmental pattern has emerged as maybe not your classic PLA2R. So what has been shown now that the segmental pattern of injury is classically NEL1. Okay, you don't even need the staining. So when you see segmental, ask your pathologist, segmental pattern of injury usually is NEL1. But you all know, and we have seen this now in multiple publications, it's not just PLA2R anymore. It's like the antigen, has been exploding, right? It's like raining antigens of membranous from the Mayo Clinic. So here's sort of a summary of what's been described. If you look on the left, malignancy has been associated with NEL1, thrombosplerosis, and PCHD7. Autoimmune is your classics exotosin 1 and 2, which is your lupus 1. And there's one with neurological diseases. And then you have FAT1 with stem cell transplant. Infection is your syphilis. There's medication associated one. So again, NEL1 comes there too. So NEL1 is not just malignancy. We've seen that with endogenous meds from India or mercury, herbal meds, checkpoint inhibitors, you name it. Pediatric, there are some as well. So I can say that in the last 5 years, the second most common membranous is NEL1. It doesn't have to be malignancy associated, but we have seen NEL1 from drug-induced more commonly than cancer, and then idiopathic, just treat them with Rituxan, they get better. So solid tumor-associated glomerular diseases, membranous is the most common, and cancer-associated membranous, we think that the malignant tumor, the cancer cell, maybe the endogenous protein is coming from the cancer cell that is NEL1. That's not been really proven. Or there's an antigen-presenting cell that's triggering a NEL1 production. No one really knows why those antibodies are more specific in cancer. But this is sort of a schematic that we worked on for the recent Brenner and Rector that's coming out. And it basically adds, how can this be malignancy associated on the right versus primary, sort of the clues like I talked about, without the staining, with the staining. Okay, so we went over all of this. This is just a summary slide. He does have all the things. He has a history of smoking. He did have a segmental pattern of injury, and maybe there's an L1 positivity. We don't know yet. So, but this is sort of just a summary that the NEL1, thrombosplerosis, and PCDs H7 and PLAR2, right? The degree of cancer is in that direction. So 33% of NEL1 have malignancy, 10 to 20% thrombosplerosis, you will find a malignancy. But NEL1, again, just to emphasize, is not just malignancy. These are all the things we have seen NEL1 with. You can see the most common, I would say, again, is indigenous meds. Alpha-lipoic acid is a big one, mercury, NSAIDs, checkpoint inhibitors, and then cancer. So the patient had NEL1. It was positive on the renal biopsy. Then the scan was done at the same time, and it showed a lung mass, confirmed non-small cell lung cancer. Treatment of the cancer led to complete remission of the membranous. As soon as the treatment for lung cancer these days is pembrolizumab, pemetrexate, cisplatin, or carboplatin. As soon as the patient was started, a month after that, the proteinuria completely disappeared. So it is definitely possible to see this, and they have a very good prognosis if you treat the underlying malignancy. Other GNs with solid tumors, minimal change, FSGS, MPGN, crescentic are rare. Crescentic, think about lung cancers. IgA, think about renal cell. AA amyloid is a big one with renal cell and prostate cancer. Actually, serum amyloid A was, before PSA was discovered, that was a marker for prostate cancer. So, untreated prostate cancer can really produce serum amyloid A. So let's go to this one. This is a fascinating case, and maybe Baljinder has seen this one at one of our GN chats. This is a 67-year-old female with history of CLL and cryo, presented to an outside hospital with severe nausea, vomiting, and diarrhea. She recently had a change in treatment from acreluprutinib to venetoclax. So that's like ibrutinib used for CLL. It was changed from that to venetoclax. Let's go back. 14 years ago, she gets diagnosed with CLL, no treatment for 10 years. 4 years ago, she had AKI and nephrotic range proteinuria of 8 grams. Immunofixation showed IgG lambda. Bone marrow showed small lymphocytic lymphoma, CLL. That goes along together sometimes. A kidney biopsy was done. It showed MIDD with IgG1 lambda and MPGN pattern of injury with nodular pattern. So this was associated with CLL because it's possible that this was producing a clone, and patient got obinutuzumab, that's treatment for CLL, but then the pandemic happened, but there was complete renal remission. And then 2 years after that, she was started on acreluprutinib for CLL, and she remained under good control from the kidney standpoint and her CLL. Just 2 months prior to this admission, she was changed to venetoclax due to insurance reasons. On admission, she's hyponatremic, AKI, hemoglobin is 8, thrombocytopenic, large blood in the UA, 300 protein. She worsens despite IV hydration, and dialysis is started. She gets steroids for 3 days with presumed GN, no PRBCs were transfused. Now she gets PRESS syndrome with significant hypertension, and then she's transferred to our hospital from this community hospital. On exam, she's hypertensive. She is no focal deficits. She has really edema, no edema, and really done nothing else except an IJ catheter for dialysis. Hemoglobin is 8.5, platelets of 70, BUN creatinine 35 and 5, albumin is 2.8, LDH is high, hapto is undetectable. Okay. Complements are low, 53 and 2 for C4. Immunofixation, again, IgG lambda. Kappa is 2, lambda is 51. Kappa lambda ratio is 0.04. Prior kappa lambda ratio was 0.16, so it's lower. So there's more lambda. The serum cryo, given our history of cryo, is negative, and protein creatinine ratio is 2.5. Here's a kidney biopsy. You can see some glomerular hypercellularity. There is some, some intimal sclerosis and widening. There is some interstitial fibrosis there. Electron microscopy is showing you double contouring there, with some effacement, segmental effacement of foot processes. So you can see the double contouring and segmental foot process effacement. So with these findings, you would actually, so let's go to the EIF also shows more lambda predominance. So the final read is acute on chronic thrombotic microangiopathy, given the double contouring and abundant fibrin thrombi that were noted. It goes along with a presentation of TMA, haptoglobin was low, anemia, thrombocytopenia, acute tubular injury was present, but there was also this IgG lambda MIDD with focal MPGN features, but not that many deposits. It was more non-deposit-like MPGN pattern, which goes along with TMA. And there was some moderate arteriohyalinosis. Remember, her prior biopsy had showed IgG1 lambda, similar to this, but there was no TMA in that. What is her TMA related to? Underlying CLL, infection, Shiga toxin was negative, complement-mediated TMA, immune complex-mediated process, or drug-induced for venetoclax. I know it's not going to be easy. It's a real case.
Complement or drug. Some vote for 3, some votes for 5.
Okay. Yeah. So a very nice reasoning there. Everything at the end is complement mediated, right? So we know that it's triggering complement pathway, but what is triggering it? We're going to treat the complement part. That's the symptom. What is the trigger of that symptom, right? Is it the change in the medication? Because that's the only new thing that happened. They went from ibrutinib to venetoclax. So could it be the venetoclax, or could it be the fact that now the CLL is not controlled because you switched the medication? Those are the only two possibilities that made sense to me. Why else would this happen, right? So here you see complement testing with more detail while she's on dialysis. You can see that the factor B antigen were all normal, but the MAC complex, the terminal pathway is significantly elevated. Okay, so we know there's MAC complex activation. So while we're waiting on what the trigger is, it's not unreasonable to treat this patient like a complement-mediated TMA, at least till we figure it out. Fair? So how would you treat this patient? Eculizumab, plasmapheresis, aggressive treatment of CLL with previously successful agents, 4, repeat bone marrow and decide the treatment, treat the underlying infection. This is not CLL related. The ball's in the nephrologist's court.
Yeah.
The hematologist will just do
this is hard. Yeah. We have 1 vote for 2. Yeah, a couple of them are saying 2, and 2 or 1, interestingly enough. Yeah, I would have thought CLL maybe, but.
Yeah, it's a tough decision. Again, some places don't have eculizumab. People do pheresis, but what are we pheresing here? There's no ADAM TS13 is not depleted. There's no antibody production. So what are we really pheresing? Venetoclax is not associated with TMA. It's more of a tumor lysis drug. If you haven't read the recent New England Journal tumor lysis syndrome paper. It's a nice review just published yesterday. And venetoclax is the #1 drug-induced TLS. So it's not classically associated with TMA. It's more of a TLS AKI. So this is what we did. Patient was restarted on the original agents, okay, because the bone marrow showed stable CLL, but we thought this was underlying CLL triggering because it was well treated with the prior agents. Why are we switching them? We started eculizumab as a temporary bridge. Those agents worked. Patient actually came off dialysis and creatinine was 1.85 months later. I just saw her a year later and creatinine is 1. And all the TMA parameters have resolved. We then stopped the eculizumab after 6 months because I used that as a bridge till the CLL treatment was done. So in summary, this was a CLL relapse or CLL going crazy. But the first biopsy CLL did only MIDD. For some reason, in the second biopsy, the patient also had a TMA triggered by the CLL, in addition to MIDD. So two pathologies from the same cancer. So heme malignancies in the kidney, right? So B-cell disorders, lymphoma, myeloid diseases, lymphoma, and myelomas. I'm not even going to go to the myelomas, right? Because that's a whole different lecture, paraproteinemias. But when you see an MPGN pattern of injury, let's go back a little bit. This patient had two biopsies, both MPGN pattern of injury. An MPGN pattern of injury is very important, not the disease, can come in three variants. The first is C3 only. If there's only C3 immunofluorescence deposits in the immunofluorescence, then you're thinking C3G or dense deposits disease. And can a malignancy trigger that? Yes. MGUS can trigger, or even monoclonal gammopathies can trigger, especially lambda. Lambda likes to bind with factor H, and then you get antibodies. So you actually can get C3 or TMA just from MGUS. Immunoglobulin deposits. So C3 and something else, IgG, IgM, IgA. If it's a full house, you're thinking polyclonal. That's either malignancy or vasculitis. But there's some polyclonal cancers that can do it too, like cryo, CLL as well. But if it's monoclonal, it's very simple. IgG kappa with C3, IgG lambda, that's easy. That, it's going to be some paraprotein process. And then we have no deposits. When you actually have posse-immune MPGN, right? We actually have no C3, nothing. That's TMA. That's MPGN is the pattern of TMA. So really think of MPGN as a pattern of injury. You won't miss then the pathophysiology behind it, because the IF will be so clue, in the diagnosis. I don't need the EM much, because only place I know the EM will be helpful is TMA, because there's no deposits. Everywhere else is going to be deposits, so who cares where they are? Because I know the IF is monoclonal, I'm looking for the cause. That makes sense? So the ones that are more confusing are these myelodysplastic and myeloproliferative syndromes, and they're kind of related in a way, but the diseases that come together are CMML, atypical CML, and those MDS, myeloproliferative disorders. They both can kind of merge together. But are they causing kidney disease? Yeah, they can. They actually can cause tubular damage and glomerular damage. Okay, the classic glomerular damage is AA amyloid, IgA, FSGS. But you can see, myeloid-associated lysozyme production in some of these diseases. So if you look at it, the one that you should take home with CMML is lysosomal nephropathy with tubular interstitial disease. But the rest, GNs are very, very rare, but we have seen some. But don't ignore these smoldering diseases in the heme world, because they can actually affect the kidney. What about Waldenstrom? People don't talk about that one. We hear about myeloma, we talk about all these, but Waldenstrom is a paraprotein-like disorder. And even though you might not think, but 80% of the kidney biopsy findings in Waldenstrom are paraprotein-like. Okay, so AL amyloid is very common in Waldenstrom. So you can have both of them go together. Cryo is very common. 50% of kidney biopsy findings of like the non-amyloid type are cryo. So cryo, really you should be looking for Waldenstrom in the Harvoni era. This hep C is almost gone with the in the kidney. So in the world of Harvoni, cryo GN to me is Waldenstrom till proven otherwise, or CLL type disease. So keep an eye on, convince the hematologist to marrow these patients. Okay. Yeah, you can give Rituxan, probably will work because you're treating a B-cell disorder, but you're basically waiting eventually. And then you have the interstitial diseases, which are rare, like Cas nephropathy, because again, it's a type of paraproteinemia. So CLL, So that's the disease our patient had, right? When you look here, this was back in 2018. When you do a systematic analysis of what's been published in CLL and glomerular diseases, the most common was MPGN. But in 2018, if you look at the old data, there was still MPGN would include TMA probably, because the old way of classification of MPGN, you're missing things. Okay, so we don't know how much of the TMA, there's 6 cases, but I'm sure some of those 37 MPGN were really, some of them were TMA. But again, a lot of those MPGNs could be cryo too. We don't know. AL amyloid is very common with CLL. And then you get this classic board question of immunotactoid. If on the kidney biopsy, it's usually CLL. But while the most common GN is MPGN pattern of injury for CLL, but then you look in the EM, you might find immunotactoid. So it's still CLL. Okay. What about the other way around? Cancer-associated TMA, because this patient also had TMA. So TMA, you can have multiple mechanisms, but solid tumors have been seen with TMA, liquid tumors, CLL, leukemias, paraproteins can trigger a TMA with that deposition, and the classic one is stem cell transplant. Okay. TMA with solid tumors is not as common as liquid tumors. It's very hard to distinguish this part of the usually when you have TMA from a cancer, there is bone marrow involvement of that solid tumor, usually. And what's the mechanism? When you see a figure that's this confused, that means nobody knows what the real mechanism is. They just come up with, some arrows. Okay, this may be triggering this might be triggering this, and activating endothelium and damaging it. But really, nobody's proven anything in such a rare disorder. So we'll move on to the third case because it's kind of related. This is a 31-year-old with minimal change, comes for a second opinion. And he was diagnosed at the age of 28 and since then had prednisone responsive minimal change. Second and third flare-up required tacrolimus. He wants to consider rituximab. Really nothing positive except for he has proteinuria, he's a musician, his creatinine is 0.9, and serologies are negative. We looked at the prior biopsy and it showed dusting on IgG immunofluorescence. So when you see dusting, you're thinking more anti-nephrin-like pathology. What do you do next? Treat with Rituxan, rebiopsy to make sure no FSGS, look for a malignancy such as lymphoma, look for a malignancy such as thymoma. The resistant minimal change disease coming to you for a third opinion.
People are thinking not many responses for this one. Oh, they are saying, Mark is saying this is a cancer talk, so it has to be cancer.
Good, thank you. Somebody's actually using some common sense to answer the question. So a lot of people will give this patient Rituxan, right? Because there's a resistant to Tacro, resistant to steroid, which is not unreasonable. But I have seen now multiple cases of thymoma causing minimal change disease. When you have a resistant minimal change for years, especially a young adult, really look for thymus pathology. And removal of thymus in this patient resolved the minimal change and never had a flare-up after 4 or 5 years. So thymoma and minimal change is a real association. I don't know if there's a nephrin association there or not. And I know Astrid will try to look into those things. But minimal change is probably the most frequent kidney biopsy finding with Hodgkin's and non-Hodgkin's, but there have been associations with thymoma and renal cell as well, both minimal change and FSGS. What is the association? Maybe T cell regulation, triggering this podocytopathy, because thymus is more of a T cell structure. But then we are saying it's anti-nephrin, which is a B cell production. So it's not really clear what exactly is happening there. Maybe the IL-13 is playing a role, IL-8. Those are, again, potential expert postulations from prior papers, but really nothing concrete here. So that is the minimal change with thymoma. Now let's go to case 3.5, a pretty recent, fresh case. 21-year-old female, nephrotic syndrome, postpartum, 31 grams, serum albumin of 1.8, kidney biopsy, diffuse podocytopathy with anti-nephrin staining, consistent minimal change disease, no signs of preeclampsia. So again, diffuse antinephrin nephropathy. Steroids are attempted, good response, but becomes septic. So then steroids are stopped. She develops relapse and has a PE and DVTs. A PET scan, a PAN scan done at that time rules out any retained pregnancy, no malignancy. 5 to 6 months later on Tacro and 2 doses of Rituxan and anticoagulation. The AKI improves, proteinuria is still over 10 grams, albumin is 2 to 2.5. Some improvement, but nothing crazy. Better than 30 grams. A year later, third dose of Rituxan is given. 1.5 years later, she develops nephrotic. She's still nephrotic, and we are considering obinutuzumab. For ongoing proteinuria, low serum albumin, she notices a lymph node in the right axilla. Biopsy confirms Hodgkin's lymphoma. Treatment is started with chemotherapy, adriamycin, bleomycin, vincristine, dacarbazine. Then lack of response, switch to BCOP, whatever that is, followed by radiation therapy. 1 year later, complete remission of renal and cancer. No more proteinuria, 0.1 grams, and creatinine is 0.8. A fully clinical remission for cancer and minimal change disease. Okay. Both Hodgkin's and non-Hodgkin's lymphoma have been associated with minimal change disease, and minimal change disease diagnosis can come before the lymphoma diagnosis, like in this case. So it was very strange that this patient had blood clots and a PE, so we looked for a malignancy back then, because usually minimal change, you don't see PEs. Membranous, we have, but we thought maybe it's postpartum, okay, let it be. But the Hodgkin's was hiding for almost a year and a half, hence the resistance to treatment for the minimal change disease. You treat the Hodgkin's, boom, the minimal change disease is gone. So that's that case. A 65-year-old female with history of acute myelogenous leukemia, she goes and gets a non-myeloablative stem cell transplant, and now 4 years later has nephrotic syndrome, 23 grams, and albumin is 2, creatinine is 1. A kidney biopsy is performed. What's the most likely diagnosis?
People are stumped. There's nothing in the chat. Oh,
A
A.
stem cell transplant patient with 4 years out with nephrotic syndrome.
Okay. Membranous seems to be a popular choice.
Probably a good answer, given the presentation. So the glomerular diseases with stem cell transplant, the number one is membranous, okay, by far. Minimal change, 19%, and the rest is very rare. And even back in 2008, Sangeeta Hingorani, who's like a big pediatric nephrologist expert in onconephrology and stem cell transplant, had shown that even low degrees of albuminuria post-stem cell transplant was a mortality predictor, okay, even days to weeks out. But this is sort of a schematic that says that the most common kidney pathology seen with stem cell transplant is TMA. Okay, so if you had to guess anything, even there are 9 grams of protein, some AKI, it's TMA. Okay, for the board purposes, TMA is number one answer for any pathology with stem cell transplant. Glomerular diseases or epithelial cell, not endothelial cell GNs, is the most common is membranous. Yeah, you can see some calcineurin toxicity, but that's again falls from the TMA, maybe some tubular toxicity, but most of them are membranous or TMA. Okay. Pathogenesis. So is nephrotic syndrome post-stem cell transplant a renal GVHD? Is chronic GVHD playing a role here? Why do patients, even with autologous stem cell transplant, still get nephrotic syndrome? So it's not just GVHD. Is it PLAR2 related, or is there a different antigen? And then is there some immune dysregulation? So I think allogenic stem cell transplant, that stem cell transplant from not the same person, right? So you get a stem cell from a donor, that's allogenic. Autogenic is your own cells. So you would think you would get no kidney disease with autogenic, but you can. I've seen TMA, it's been reported, and membranous has been reported, even in autologous stem cell transplant. Okay, with allogenic stem cell transplants, you are always on calcineurins. So that becomes a culprit, perhaps, because calcineurin is used to prevent GVHD. Okay, so is a calcineurin the culprit, or is it the GVHD that's the culprit is the big question that people always wonder what it's all about. So, so nephrotic syndrome could be renal GVHD, because most of the time we have seen it is when people are coming off the immunosuppression for GVHD prevention. So it's possible that it is a trigger of GVHD. But membranous is PLA2R negative in this setting. There are cases of PLA2R NEL1 reported, but most of them, more recently discovered, are FAT1 positive, this specific protocatharin antigen that is only seen in stem cell transplant-associated membranous. It's also recently been reported with membranous post-kidney transplant. Okay, interesting. It's in the transplant milieu, having calcineurins, having these drugs on board. I'm wondering if it's some immune-mediated membranous, some form of, membranous that is related in the setting of immunosuppression. That's triggering this antigen. So because it's only been seen in stem cell transplant and post-kidney transplant membranous, this FAT1. And that's pretty much the latest on that. And it's NEL1 can be, but maybe, some drug is causing that. But you see podocytopathies or minimal change disease, think of the original disease coming back. So if a lymphoma patient, leukemia patient gets a stem cell transplant, and now they get minimal change disease, hey, maybe the original heme disease is returning, and that's the cause of it. So really have them marrow the patient. So management really is tough. You biopsy, but really it comes down to Rituxan, steroids, calcineurin, or treat the GVHD perhaps. Maybe they can reintroduce the Tacro or calcineurins, and maybe the membranous will get better. Nobody really knows the right answer. Rituxan is probably my go-to thing. It doesn't hurt the stem cell transplant either. Stem cell transplant-associated TMA, though, is a real entity that sometimes is termed as bone marrow transplant nephropathy or TA-TMA, transplant-associated TMA. It's the same that you see with organ transplants as well. But in stem cell transplant, I think it's an endothelial variant of GVHD. Now, GVHD is an epithelial disease, right? You get GI tract, skin, GVHD, that's pretty much it. But when you get it in the endothelium, then it's mostly in the kidney. So there are some clues and enough basic sign papers that suggest that the endothelial injury can happen with GVHD, and it's because of decreased VEGF, increased double-stranded DNA, interferon, that leads to activation of the complement pathway, causing TMA, okay? Which then leads to my thinking that maybe they will respond beautifully to eculizumab, and they do in the pediatric world. So stem cell transplant-associated TMA, stay tuned. I think there'll be better studies coming out in the adult population that I think they do better response to eculizumab. Do not stop the CNI. People think, okay, the CNI is the culprit, but if we're linking GVHD to the TMA, that it's an endothelial variant of TMA, of GVHD, then why are we stopping the drug that's treating it? So don't just knee-jerk stop calcineurins. Maybe that's not the right approach in these patients. They don't do well when you stop the TMA, the CNI, because then the other GVHDs flare up. Or we come up with a better drug to treat the GVHD, a non-calcineurin-based treatment for GVHD. So that's where the field is right now for TMA from stem cell transplants. So in summary, the stem cell transplant-associated GNs are TMA, 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 and then membranous minimal change are the next two. And last case, a 67-year-old with lung cancer, responding beautifully to pembrolizumab, pemetrexed, and carbo, then with pembro, which is a checkpoint inhibitor therapy, 7 months. Now gets nephrotic syndrome. PLA2R negative, serological workup negative, ANCA viral serology is negative. Biopsy is NEL1 positive. Now what are you going to do? It's classic. You actually, this time we got the NEL1 staining because of segmental membranous. Are you going to hold the pembro thinking that that's what's causing this? Are you going to hold the pembro and give steroids? Are you going to continue pembro and ask about herbal meds? Are you going to perform a PET scan to make sure the cancer is going into remission? Hold pembro and treat with Rituxan.
People are still thinking. One vote for B. D, maybe. Yeah, this is a real puzzle.
So the dilemma is the NEL1 membranous associated with the checkpoint inhibitor therapy, or is the NEL1 membranous a sign that the cancer is not going into remission and the cancer is still there and we need to aggressively treat it better? So then you would not stop the pembro, right? Or is it that the patient is taking some random alpha lipoic acid herbal med, nothing to do with this stuff? So all of them are possible, right? So I would say definitely let's hold the pembro till we figure out what's going on, get a PET scan, and ask the patient, make sure they're not taking some crazy herbal stuff. Maybe they visited India and took some mercury-based drug, came back, or they went to some neurologist who said, your memory loss was best treated with lipoic acid, and they're taking these meds. So what is the data on checkpoint inhibitor associated GNs? And this comes actually from Canada. Abhijat was the first author on this. We did a systematic analysis, a meta-analysis of what's been published back in 2021, and not much with checkpoint inhibitors. What was published, the most common was a GN, a vasculitis. Posse-immune ANCA-negative vasculitis was the most common, followed by podocytopathies, followed by C3. And as you know, when you have a GN in a cancer patient on a checkpoint inhibitor, the outcomes are not going to be great because you don't know what to do. You give them Rituxan, the cancer gets worse. You give them Cytoxan, the cancer gets worse. You continue the immunotherapy, then the GN gets worse. So the dialysis dependence was high and the death was high. Okay. But membranous is not as common. Now we're seeing more and more cases of membranous, and the most common with pembro and nivo is NEL1 membranous. So we can see that with the drug, but we can also see NEL1 as we saw with lung cancer. So I think it's important that we also think about drug-induced. So these are cancer therapy associated GNs, and immunotherapy can cause GNs like we talked about. Targeted therapies like the VEGF inhibitors, tyrosine kinase inhibitors, those really are TMA and podocytopathies. We're talking about non-TMA pathology here. So you can see a lot of podocytopathies here. And then your conventional chemo, which is like anthracyclines, antimetabolites, is very rare to see GNs with those. GNs are more in targeted therapies. But then your cancer-associated TMAs are the most common, right? So that is by far the most common kidney pathology with targeted therapies or anti-VEGF, classic tyrosine kinase inhibitors, proteasome inhibitors is all TMA. With conventional chemo, yes, gemcitabine, the bleomycin can cause TMA, and immunotherapy can cause TMA too, but it's not very common. Mostly interferon-based immunotherapy. Okay, so TMA is the most common drug-induced kidney pathology, and there's some sparkling, targeted therapies as well. Now, our case, what happened was we thought the cancer was actually controlled. Let me see if I have a slide on it. No. So the cancer actually was very well controlled. So it was in remission. So the patient was not taking any herbal medications. So we thought this was related to actually the drug. And the pembro was held and steroids were given for short periods of time, and patient went into complete remission. And then patient was re-challenged with pembro a few months later with no problem. So when you have a checkpoint inhibitor or drug-induced, especially checkpoint inhibitor, membranous, you don't have to go to the conventional therapy of Rituxan, Cytoxan, Tacro. I think when a short course of steroids is good enough for a secondary membranous, like from a drug-induced itis, such as this, and it quickly responded when holding the drug and giving a short course of steroids. So they have a much better prognosis if it's NEL1 membranous. So In summary, the paraneoplastic GNs may precede the diagnosis of malignancy. And as you saw that in several cases, we had various degrees of pathology, but drug-induced is something to think about. Preceding the diagnosis of cancer, something to think about. And then sort of how to treat that in a stem cell transplant patient is also a challenging component. And I'll take questions now for the next 10 minutes.
Thank you. That was a really fabulous overview, very systematic and great pictures. I'm thinking back as to patients I've seen and probably misdiagnosed in the past. My question before, like I'm not a GN person necessarily. So my question is, how do you stay on top of all this, right? This field is evolving so fast, right? I think you see a lot of onconephrology. You're one of the pioneers in onconephrology. But how can an ordinary nephrologist stay on top of all these things? Even what you saw 2 years ago is different from what
Yeah.
you're seeing now, right?
It's hard. I think one thing I can't keep on top of all the drugs the oncologists, present, but I do keep on top of like the publications that come out that are GN related, of case reports, case series. So I know which drugs are starting to see some sort of associations with GNs. So that's basically where I find it. But I think some sort of database creation might be eventually to come, because as we grow in the oncology world, it's going to be hard to keep up with these drugs. And I think up to date, we do a pretty decent job, but every time we see cases, we make sure it's up there in the category of side effects, but it's not 100%. And also we have to be careful. Not every published case report is a true association. Sometimes it gets published, even in a very low tier journal, and then it gets cited.
Um, so Greg is asking about coverage for eculizumab. I think we struggle to get coverage for drugs in Canada, right? Eculizumab is insanely expensive. And again, that's I hope some of our colleagues chime in. But do you have any issues with getting access? I know one of your patients had to switch from
Yeah.
Pembro to venetoclax or something. How do you deal with these kind of issues?
I think it helps if the patient has systemic findings of MAHA, because then you write atypical HUS and you'll get it covered in most of the cases. The challenge becomes when it's actually drug-induced, renal limited TMA. That's where it becomes a challenge to get the drug. And I know recently we've been working with Alexion to really market that side of things. So they're actually going to come out with brochures for hematologists to make sure they prescribe eculizumab for even drug-induced renal limited TMA. So I think hopefully insurance will catch on to try to pay for that as well, because it's still a form of atypical HUS. It's just a terminology thing. I think if you document atypical HUS somewhere, it probably will get you the drug. It becomes challenging though, because it's how long do you treat it? Even if you say give it for the hospital stay, are you going to treat this patient for 6 months? Are you treating lifelong? And then it becomes even much of a challenge getting it outpatient. So what the rule we use is, if there is a genetic mutation, especially factor H, it's a lifelong treatment based on the French data. But otherwise, we do an attempt to stop at 6 months and see what happens, because otherwise it's too much for the patient, in terms of also the insurance company is going to hound you.
Yeah, exactly. When I have a TMA, I go to Todd, so I'll ask Todd to ask the next question.
No, I was just going to reply about our local experience and really echo what you've said. One of the keys is the semantics, and if you label it atypical HUS, particularly if there's a systemic MAHA, we can usually get emergency coverage. We're using ravulizumab rather than eculizumab most of the time, and the nice advantage of ravulizumab is if you get the first 2 doses in, you've bought yourself like 8 weeks.
Yes.
And even if it plays out that, yeah, we've treated the cancer, things get better, we're no longer eligible, then at least you've got them a little bit of emergency blockade of terminal complement until you can allow chemotherapy or whatever to take over. It is very difficult. Our guidelines do say, you know, a secondary form of TMA will not be covered, so you do have to kind of use atypical HUS. As you mentioned, I would still do the full workup. It's much easier when they've got the MAHA. If they've got like a low complement C3, it does take us some time to do functional complement assays, but I always send off genetics on these patients as well, because you know, if they've got a polymorphism or a known mutation, their risk of TMA is going to be much higher with another insult. So we definitely do that. But as always, happy to contact somebody in the GN group when you see one of these patients in hospital. So
thanks.
Thanks.
Yeah. Dr. Reen.
Actually, it's not that difficult to get here in Toronto, the ravulizumab. Our relationship with Alexian is very good and we can get it easily. Good thing about ravulizumab is it also works very quickly. But my question is to Dr. Jhaveri. You mentioned TMA and allogenic stem cell transplantation, maybe a host graft versus host disease. But my understanding is that actually it is the pre-transplant drugs like melphalan, high-dose melphalan and epocytes that are the cause of that. And I have a patient actually who developed post-stem cell transplantation, allogenic stem cell transplant within about 3 weeks, full-blown MAHA. And we actually ended up treating her with ecruzapop. Now she's taken up. So I'm not sure that it is really a graft versus host disease and allogenic. No question about HST, it is a graft versus host disease. That's the way I understand it.
So you're describing the degrees of TMA. You can get TMA early on, less than 100 days of stem cell transplant. That is a whole different disease. What I'm referring to is more of the chronic kidney disease TMA that you see after 100 days. That we think of it more of a transplant glomerulopathy. Like the kidney, it's very similar. It's, you know, you see triple, double contouring, just like you would see in a transplant glomerulopathy patient. So it is the same pathophysiology, we think. But it's coming from, in this case, graft versus host, we think. Now, that's not 100% proven, but in your case, so there are risk factors. So high intensity chemo is a risk factor. Radiation, the amount of total body radiation you get is a risk factor. Being a female, low creatinine, having a veno-occlusive disease. So there are a lot of risk factors. What you're describing is more early TMA, which is almost like a HUS in your case, but very early on, weeks after. That's a different beast compared to sort of a long-standing CKD TMA. So if you have a patient with CKD after stem cell transplant and you unexplained, if you biopsy them, it's going to be TMA. So that is, we think, is more endothelial GVHD.
Excellent. Yeah, thank you. Mark.
Thank you very much, Dr. Jhaveri. It was a great talk. Some brilliant cases in there, although I'm wondering if I start asking for a CT on every minimal change patient after 2 relapses, I might have a radiologist knocking on my door. But I'm more interested in I just feel as Swapna says, emerging it so quickly. And I am aware that there are now opportunities for trainees to pursue extra experience and fellowship for this. So I'm wondering where you see this going. Like, would that typically be tagged on to like a GN fellowship, and this is sort of parceled on, or do you think it warrants its own niche area? You know, should every group have one onconephrologist? Is that a little bit, you know, is that too ambitious right now? Like, where do you think it's going?
It's the $1 million question. I think, so you know there are fellowships out there in onconephrology. There are like 6 of them. Toronto is one of them. You know, there is one there by Abhijat, but there are also GN fellowships out there. We do have a combined fellowship here. We do 6 months of GN, 6 months of onconephrology. There's only 2 combined fellowships in the world, us and UPenn. So I think the future, personally, I think a combined fellowship in GN onconephrology is ideal because they're sort of related, and I learn from each other. I use the onc drugs to treat the GNs, and the side effects are, what we see in onconephrology. And down the road, monetary-wise, if you combine two specialties, you are more marketable from a business standpoint. You can't make money in the private practice with just doing GNs. So it's sort of somehow you have to market this also to make money for the person graduating. They should have a job that's more fundable. Two, you can even do this within the 2 years or 3 years of regular fellowship by creating tracks. So, for example, if you're interested in onconephrology and you have a content expert within your division, then you spend more time with them within the 2 years rather than general nephrology. So kind of creating that sort of niche within the regular fellowship. So we have programs that have done that as well. You don't need to do the extra year unless you really want to go into academia and really publish and get research funding. Then I think that third year is good. But even within the 2 years of fellowship, creating tracks of different types can really enhance your experience. It's just seeing more patients.
Yeah, thank you.
Yeah, I think that is really, I've been a strong supporter that we really need to have onconephrology expertise everywhere. Like we have a really large cancer program here in Ottawa. So it makes sense, right, for someone to be doing a lot of that.
I mean, you don't even need training for that. You just start seeing patients within a year or two. You'll have enough experience and volume, and then you be part of a network that you share and discuss. And soon you'll probably be the expert in your institution.
Right. I think that's how it started with you and Abhijat and Aisha and others. But do you see that this is going to be an issue that in the future they'll say, oh, you need to do a fellowship before you can call yourself an onconephrologist?
Yeah, I think you have to kind of see enough patients to call yourself that. You can't. I think I've seen people immaturely call themselves that and, have just graduated fellowship. And I think it's really not fair to the patients and the referrals. I think you have to be a little bit humble about that.
We can talk about this topic forever because I think it's really, really important. But one last question I forgot in the chat. Jeanette was asking is, along the TMA discussion, going back to that, do most of these patients end up having some underlying complement abnormalities?
So the French actually studied this very well. There was actually a nice paper in KI last year, I believe, and they looked at drug-induced TMA, even primary systemic TMA, renal limited TMA, and drug-induced TMA, especially cancer drug-induced. You don't find that many genetic abnormalities when you look for them. So it's not what we expected, but it is interesting that you don't find as many. But we still check because if we find something that's more, then I think the lifelong treatment is an important component to that. But it's a good question.
Fantastic. Yeah, thanks again. This was a fabulous talk, wonderful cases. And again, for those who are on, we do record all these talks and they'll be available on our YouTube channel. So wonderful to have you here, and we'll meet you in person at some conference in the future.
Thanks, Swapnil. Thanks for the great questions, everybody.